doing safety course, okay, which is a lot. And then I'm doing permanency. And then you're doing well-being. You know, I really feel better with you doing it because I feel like, you know, this is really fun. And then I can do conclusions or you can do conclusions.
Right.
You were sitting here, since you're trying just about everything.
I think we'll probably physically move, because it doesn't make a lot of sense. We can't touch the laptop.
We're not just going
Good to know. Good to know.
I did that.
Okay. So we can't
Just so no one else would feel embarrassed.
So
So we use the clicker to move forward.
Right.
The clicker. She told you about the mic.
I don't actually know.
It might actually make more sense. We're not talking.
We create a safe zone around the computer.
Yeah.
So nothing goes wrong. And we have some water for you both. And we're handing out this, you created this really great summary.
Lovely.
So we're going to give this out to the network here in the audience and then after the event.
Do you tell them how many people we have for the webinar?
No, we have 40 people RSVP'd for the webinar.
Good. Is that a
Correct. Yeah, we've never done this before. So,
congratulations?
yeah, no, it's good. It's good. I think there's several DSS directors on. There's a lot of kind of our member organizations from Child Advocacy Network that'll be on Hill and Raleigh. And yeah, so it should be good.
Good. Well, the local DSS directors is a group we
And
haven't
so we're
necessarily
broadcasting
reached.
now.
That's good. That makes me happy. I got that email.
Mike?
Yeah.
Yes. Good to know. Just want to make sure. Hot mic situations be in trouble.
Mike in the room.
John Kerry got busted this weekend on hot mic.
Right.
How's it going, Ann? Doing well.
But I don't know what your favorite and I'll just get choose. I'm running.
Good to see you. Hi, Tom. Good to see you. I don't have to teach you about not quitting.
You're welcome. You doing all right?
There's one here instead. Yes.
First time to do it.
Or just do some shopping. All around be like a good man. And Rob, you know our association has.
They do.
Setting stuff in.
I think you have. If I didn't send you, you didn't get an email from me this week, did you?
About that?
Yeah. I think you have.
Okay.
So she's
Oh,
you can see her?
I just saw, I was looking at the
Yeah.
And I saw that and I thought, wow.
Well, actually, she's
Really quickly, really sad.
Well, I don't know about that.
Kind of diagnosed late stage cancer.
Hi, I'm Judy. Nice to meet
He
you.
was an organized man.
He wasn't nice.
Then I turn around and she tells the media,
Yeah.
I think so too.
yeah.
Did you get an email from me with the latest information?
I did.
For the dues?
Yeah.
Okay, I didn't know. My family's updating me with the laptop, and it's very sensitive to my fingers. And so, with the board meeting coming up in September, if we don't bylaws we look at, we will be, we'll be part of the budget. Is it, can you let the president know or let me know, when we can get a copy of this? Are they available? That's okay. I brought another copy in case you didn't get one.
Oh, yeah, of course.
She said, 300 dues.
I like that.
I want to come back around.
Medical
I just want to
Make sure you're seeing what your kids are seeing.
You need a copy of the
Yes.
Yeah, we can share those.
Okay.
I mean, there's no dues. Yeah, okay.
And I don't know how nitpicky she is about all this, but I think she's realizing that even though we don't lobby, that this is years of protection, which you and I long know. But, so is there any way that's being done forward to, you got this email? Okay, great.
How are you?
I'll see you.
Okay, that'd be great. Thank you so much. Because in September, it will be at that point.
Of course, it's an important
And we're ready to get up in front of everybody.
I hear you. I appreciate it.
Okay.
Gary.
I don't
Hey,
know
Rob,
that
how are you?
they've
Good. How are you?
That's my
So Denny's, I'm getting it.
Hi, Gary.
How are you?
Yeah.
If you want to, Layla, you could get on the mic and say, still waiting for a couple people to show up inside.
You know, I went out to the receptionist desk and asked if she could go to the live link, and they're saying this.
You okay? How's it going?
It's okay. I'm gonna and then trying to coordinate their meeting schedule.
I wonder where they're going.
Gotta get in a rhythm.
Yeah, the trend probably, I'm sure, was a lot.
Yeah.
Diana is
Yeah.
very well.
Really?
That was a lot
She's
to
getting
think about.
7
Trying to
to 8%.
figure out who's trying to figure out.
Is she doing something different?
I will.
Yeah.
Right. That's not even the most important thing that's happening at the moment.
No. They could potentially be, but right now it's not.
Yeah.
And I don't think they didn't even provide a sign. Yeah. When they were done.
Sarah, I thought you the other.
Oh, yeah, I know.
I mean, I think I calculated for us to be around 2,000 or something.
Well, I have to,
Next line.
because we're speaking to the company and we're speaking to. So, and I need to.
Really, no, everything.
Yeah, I might stand and.
Because I know that we didn't get a lot out of first thing. All right, we're gonna give it a couple more minutes for people to arrive here in the office. Really more sharing.
So, yeah, that was my understanding when I had one conversation with a guy from Iowa.
Which could be really good. I mean, you know, they go from communications together, having the 3 or 4 different states getting together. There's a lot of value. Could be a lot of value in that.
Right.
It's structured well. It doesn't say. To me, right now, there's not enough. I'm gonna give all a couple of them now, which would be highlighted. There needs to be more. How are we gonna do that? If we're able to put together some proposal and get it on the table, which I think throw out in case you guys have you know,
Yeah.
then we could get some things going and get people scheduled for meetings. And then we can really valuable. So we can fairly find the approaches. Yes, it's an opportunity to be a leader in that.
Yes, that's why I thought we didn't go out.
And then, questions?
And they have, you know,
We're both. Yeah.
A lot of it depends on state level what they do. It's not safe to just watch my ads and aren't.
All right, Rob, you know your group, it's just.
Yep, we should do it. hopefully we'll have some more people walk in, but let me just do a quick welcome and then we'll get started with the webinar. Hey folks, thanks for coming today. We're going to go ahead and get started because we have folks online waiting for us to start the webinar, which will be on the LongScan, as everyone knows from the emails I sent out. So we're going to forego the kind of typical introductions we do. We will, after the webinar's over, of course, introduce Linda Saturno, our new executive director, who's right here. So you all got a chance to meet her. But in the meantime, I think we're going to go ahead and get started with the webinar. And Layla, who is closing the doors, is going to introduce the subject of the webinar and also our two presenters today. So Layla, I'm turning it over to you.
That's so formal. Thank you.
Sure. Don't forget and she's going to be speaking into a mic so that the folks on the webinar can also hear us.
And so a little bit of insider information for the folks who are in the room. This is our first time doing this, using this technology. So you are all part of the Trailblazers, and you're witnessing history. And we appreciate your flexibility in working with us as we figure this out. And so I want to welcome everyone that's joining us online for today's presentation. My name is Layla Bell. I'm the Director of Research and Data, and I'll be your moderator for today's presentation. We will be discussing the LongScan study with Dr. Jonathan Koch, a research professor of maternal and child health at the UNC Chapel Hill Gilling School of Global Public Health, and Liz Dawes-Knight, who is a research scientist at UNC Chapel Hill Injury Prevention and Research Center. If you have questions during today's presentation, you're welcome to submit them via your Google Plus account or to tweet them at NCKidsCount using the hashtag LongScan. For the benefit of folks that are joining us online, NC Child is a new child advocacy organization that works to promote the health, safety, and overall well-being of children in North Carolina. And we do that in a few different ways by making sure all children have access to the basic building blocks that will enable them to thrive later in life. Today's presentation is being hosted by the CAN Network, our child advocacy network, which is a group of more than 50 service providers, professionals, and other nonprofit organizations that work together to ensure the health and safety of children in North Carolina. I am pleased to introduce today's presenters. Liz Dawes-Knight is a research scientist and associate director for education, training, outreach, and translation for the UNC Injury Prevention Research Center. She was an investigator on the LongScan study for over a decade and principal investigator of the Doris Duke Foundation-funded LongScan Dissemination Grant from Science to Practice, both of which resulted in the findings that you will see presented today. Ms. Knight has extensive experience training North Carolina and national child maltreatment and other injury prevention practitioners through the Prevent Institute and the Injury Free Academy. Prior to coming to UNC, she directed a tri-county therapeutic homes foster care program and worked in community mental health. Ms. Knight received her MSW from New York University, and she has two wonderful sons. Dr. Koch has been a faculty member of the Department of Maternal and Child Health of the UNC Gilling School of Public Health since 1978. Until his retirement in 2013, he was a distinguished professor of children's environmental health, and he has returned to the university as a part-time research professor of maternal and child health. Dr. Koch's research has focused on the causes and consequences of child maltreatment and the health and safety of children in and out of home child care. He has authored or co-authored over 90 scientific articles and has edited 3 editions of the textbook, Maternal and Child Health Programs, Problems, and Policies in Public Health. He has served as the chair of Maternal and Child Health section of the American Public Health Association and the president of the Association of Teachers of Maternal and Child Health. I was actually chatting with Dr. Koch a little bit before our presentation, and I asked him how long he was involved with the LongScan study, and it was pretty amazing. He said that he was the PI of the NC local site for LongScan for 22 years, and then the PI of the kind of 5-site consortium for its last year. And if you count his full length of involvement with the project, from the funding of the original grant, from the HRSA that supported recruiting of the birth cohort in 1986 through today. It means that he's been leading this effort in North Carolina for 28 years, which is amazing. So we're excited to bring them both to you today, and we'll begin our presentation with Liz Knight.
Thank you, Lila. I'm going to start by telling you a little bit about the studies themselves. So what is LongScan? LongScan was funded for 2 decades by the Children's Bureau of the Administration on Children and Families, with additional funding from NIH and the CDC. And From Science to Practice was funded by a grant from the Doris Duke Charitable Foundation to IPRIC to disseminate the LongScan findings. So LongScan was funded in 1991 to follow families for 18 years. There were 5 sites around the country, and 1,354 families at varying risks for maltreatment were recruited and retained in the study. And the PI group included a variety of research disciplines, including psychology, pediatrics, social work, public health, and epidemiology. The From Science to Practice initiative, we took our findings on the road. We took our science findings on the road, and at each of our 5 sites around the country, we invited key stakeholders to come and discuss those findings and place them in the context of their current sort of practice and policy challenges, and also to make recommendations based on our findings. So you'll see throughout we have findings, and then after we've discussed the findings, we include recommendations. And those recommendations come from these meetings around the country from our key stakeholders after discussing our scientific findings. Some of our sites included former LongScan subjects, and they also included adults whose children were involved with CPS. We held a 6th meeting in Washington, D.C. with sort of national leadership to discuss the findings and recommendations that had been drawn up around the country. And from the discussion in Washington and from the 5 meetings around the country, we drew what we considered to be the most pertinent and what the stakeholder groups considered to be the most pertinent and relevant findings to current policy and practice challenges. So that's what you see here today. If you go to the LongScan website, you'll see what, Jonathan? Something like over 130 publications. So if you want to hear more about this work, or you want to know more about specific findings, that's where you'll find it. We worked with a health communications specialist to put the findings, sort of take it out of science speak and put it into real English. So findings from our study fall into 3 main categories, and that includes safety, permanency, and well-being. And I'm going to turn it over to Jonathan now, who's going to talk about safety, findings related to safety.
Thank you, Liz. Let me add how pleased I am to be here, and those 130 articles that Liz mentioned did apparently not get beyond the intimate circle of researchers in the first 20 years of the LongScan project, which is why we went ahead to obtain money from the Doris Duke Charitable Foundation in order to recast those findings into language that was more accessible and more appropriate for policymakers and providers of services for families with children who had been reported for abuse or neglect. And Liz is being a little bit modest. She was the leader of the Doris Duke Charitable Foundation project, as I had been the leader of the LongScan project. So starting with safety, one key point that came out of our research is the fact that we can identify children who are at risk for abuse and neglect from the moment they are born, using a combination of risks which often persist from early childhood through adolescence. And it's especially gratifying to be in the room with Tom Vitalioni, who was one of the people who created the High Priority Infant Identification and Tracking Program back in the 1980s, and that was the basis for the risk screener that we used for identifying children at risk at the time of their birth in hospitals all around North Carolina. So I owe a lot to Tom for that leadership and guidance. Thank you. For children who come into contact with child protective services at an early age, Maltreatment is only one of a multitude of adverse experiences. You've all heard of the ACE study, Adverse Childhood Experiences, and I believe there are 7 adversities that Felitti and Anda used to identify retrospectively adults who had, as children, had been at risk. 4 of those 7 or 3 of those 7 related to maltreatment, but there are other kinds of adversities which both the subjects in Felitti and Anda's study as well as the subjects in LongScan also experienced, such as family dysfunction, drug use in the family, involvement of family members in the criminal justice system, adult mental health issues in the family, and possibly homelessness. So we were able to see in our subjects that same constellation of adversities, and maltreatment was only one of them. A report of child abuse or neglect, whether substantiated or not, is a sign that families are under stress, probably from some combination of adversities and not just abuse or neglect. As Liz explained, there were 5 local sites around the country that participated in LongScan. North Carolina was one of them, and we used the subjects just from North Carolina to create our own scale of adversities and called that cumulative risk. So we were able to, in the first year of life, label our subjects according to how many risks they had. And as you can see from this graph, children with low number of risks in early childhood in the first year of life, only 0 to 2 risks, had the lowest risk of being reported for maltreatment up through their first 16 years of life. And the medium risk group had a medium risk of being reported, and the group with the highest number of those adversities, 6 or more, were those who were reported most frequently to Child Protective Services. So as Liz said, for every set of findings we have some recommendations. Our recommendations that derive from this particular feature about safety would be to identify the highest risk infants prior to birth and at birth in order to prioritize services in the face of shrinking budgets. You know, being from public health, we're always interested in prevention. If we can identify children before they're abused and neglected, we think in the long run that would be beneficial not only for families but also to our budgets. We need to consider cumulative risk as an indicator of need for services even before maltreatment becomes manifest. We need access to mental health assessment and treatment for the parents of at-risk or maltreated children, and that's critical to prevent maltreatment and to ameliorate the effects of maltreatment. And lastly, this includes children who have been exposed to violence in the home. Among the findings that we had were that children who were exposed to violence between adult family members in the home showed the same kinds of adverse outcomes that children who actually were victims of violence or neglect showed themselves. Among the different types of abuse, no one type of victimization definitively predicts worse outcomes for children than others. So our conclusion is that no subtype of maltreatment is better or worse than any other. Maltreated children, are typically exposed to multiple forms of maltreatment. We may pick them up in a CPS referral for a particular maltreatment, but before or after that, they're likely to be exposed to other forms of maltreatment. So it's really a false classification to say this child is an abused child because that child may also have been neglected, but we didn't pick that up before, or may become neglected later on. Same for sexual abuse and psychological maltreatment. And again, we also should include witnessing violence over their lifetimes as another form of maltreatment. So our recommendations with respect to multiple exposures is that we need to assess a broad range of experiences, including witnessed violence and psychological maltreatment, in order to better match the services to the family and the child's needs. And the assessment of maltreatment should be multidimensional, including age of onset, types of maltreatment, severity of maltreatment, and chronicity. The LongScan research included LongScan research assistants going to local Child Protective Services agencies, looking at the records of the families in our study and reclassifying the type of maltreatment based upon what they read in the records, not what CPS necessarily reported. And that was another reason why we discovered that children who might have been reported for one particular subtype of maltreatment may actually have experienced many other types of maltreatment at the same time. Witness violence, I've mentioned that a couple of times already. The risk of aggression, anger, and depression for an 8-year-old who witnesses violence is similar to that for a child who actually experiences physical abuse. The violence in the home has negative consequences for children, even if not directed at the children themselves. Verbal aggression would be considered as adult violence. Both female to male as well as male to female aggression and violence need to be considered. Early problems with aggression that are experienced by children often persist into their own adolescence. So we would recommend that we need to broaden our view of intimate partner violence, what we now call IPV. We recommend be called intimate partner aggression and violence, so that we can subsume verbal aggression into this category of exposure. We need to address child witnesses, not just child victims, in assessment and intervention. We need to increase public awareness of the detrimental effects of intimate partner aggression and violence, including verbal aggression and violence perpetrated by women. Exposure to intimate partner aggression and violence may result in outcomes like school problems, mental health problems, and health problems for children, and violence has high risks to children whether they are victims of the violence or simply witness it. Professionals dealing with children should be trained in recognizing and responding to witnessed violence. As soon as intimate partner aggression and violence come to the attention of any professional or for children in these homes, psychological assessment and services, we know about the dichotomy, the split between the women's shelters, shall we say, is one example of an intervention that supports women who have been victims on the one hand versus child support and child protection on the other. Those two have to come together because family violence problems are family problems and not just women's problems and not just children's problems. We need to increase screening for intimate partner aggression and violence by asking the children directly about witness violence. And at LongScan, we had a lot of experience asking children directly about their exposures. We started at the age of 12, asking children about all the types of maltreatment and exposure to violence that they could have been exposed to. And Liz led a couple of studies that demonstrated to our satisfaction that we didn't harm the children by asking them about their exposures and their experiences, and we didn't lose them as subjects to the research when we asked them about their exposures and experiences. Lastly, don't forget that aggression and intimate partner violence can be perpetrated by women, and so that has to be considered in our worldview as well. Then there is the issue of neglect. Neglect is the neglected subtype of maltreatment in a lot of ways, and I think we don't appreciate how devastating the effects of neglect can be. We somehow think it's not as important as abuse, for example. It's more difficult to identify than physical abuse, but in children under 5, neglect is more likely than physical abuse to lead to aggression in later childhood. So the study that we did looked at children at age 8 and compared their experiences with abuse or neglect before they were 4, and we discovered, as you can see from this graph, that the risk of aggression in later childhood was greatest for children who had been exposed to neglect in the first 2 years of life. And any exposure to abuse or exposure to neglect between 3 and 4 years of life were not as significant a predictor of aggression as that early exposure to neglect. So early neglect is especially harmful to children, and neglect is more likely when fathers feel less effective, less engaged in parenting. So our recommendations here are we need to devote more attention during both assessment and related interventions to very early neglect and psychological neglect. And we need to reduce barriers to fathers' involvement in child rearing. And then the issue of psychological maltreatment. Again, it's an overlooked component of childhood maltreatment. The overall impact of psychological maltreatment that we saw in our subjects may have been significantly underappreciated until now. Psychological maltreatment, like neglect, is significantly more detrimental to children than is commonly perceived. So therefore, we recommend that all professionals dealing with children should be trained to recognize and respond to psychological abuse, and in families with reported psychological maltreatment, we need to address the need for services for that type of maltreatment as well as for abuse or neglect. And lastly, I think under this rubric of safety is the issue of suicide. Maltreated children may not be safe from themselves. About 20% of the abused and neglected children in our study had thoughts of suicide, which were seen in children in our study as young as 8 years of age. So we need to assess children who are victims of maltreatment for risk of suicidal thoughts and suicide attempts, and we need to remove barriers to service, including access to training and support around children's mental health needs. So now it's time to switch to permanency, and back to Liz.
Thank you, Jonathan. So here are some quotes from adults who were in the LongScan study as children, and I don't think some of these will come as any surprise to you, knowing that we had kids that were placed in as many as 29 different homes between the ages of 3 and 18, and kids who sort of shuttled back and forth to parents to foster care, to parents to foster care, and as a result had multiple placements and chronic instability in their lives after initial placement into foster care. So I think the message that I'd really like to share with you all today probably won't come as a surprise, but that is that permanent placements after a child has entered foster care and exited foster care into what is assumed to be a permanent placement are frequently not that. They're frequently not permanent. They don't mean, a permanent placement does not mean a child is safe. Maltreatment re-reports occur in every permanent placement type, and that would include adoption, that would include long-term stable foster care, and reunification. So reunified youth who've been reunified with their biological families are most likely to be re-reported for maltreatment after a permanent situation has been attained. And long-term patterns of chronic re-reporting are observed in all placement types. And here is a graph that shows you in different age epochs the percent of children in our sample who had entered foster care, left foster care into a permanent placement, or were in what was regarded as a kind of permanent foster placement by type. So the unstable is unstable foster placements. The gold line is stable reunified. You'll see at the age of 10 to 12, almost 40% of those children had re-reports. And, you know, going back to the point Jonathan made and going back to the ACEs study, permanent instability is only one of the ongoing forms of instability that former foster care youth experience. Even children not changing caregivers experience multiple moves, school changes, household changes, people moving in and out of the homes, and ongoing adversity. And continued instability for these kids is associated with more problems. And some adopted youth who appeared to have fewer problems early on evidenced a lot more problems during adolescence. So here you have a graph that shows you that even youth in permanent or stable placements experience ongoing adversity. If you look at the bottom line there, you have physical abuse, sexual abuse, emotional abuse, neglect, other kinds of adversities. And then you have the type of permanent placement and sort of how often those things occurred, at what percent within this sample those things occurred to kids in these permanent placements. And you'll see, if you look at the sort of mauve line with the square boxes, those are stable adopted. You'll see there's a great deal of household substance abuse and a great deal of adults in their households with mental health issues. Stable reunified, again, lots of household substance abuse and mental health issues. And there's a spike in neglect. We have 60% of kids who have been reunified and are permanently with their biological families who have a report of neglect. So maltreatment re-reports and caregiver changes following permanency persist through age 18. And caregiver changes, the rate of caregiver changes, how often kids experience caregiver changes after they went into a permanent placement, does not necessarily change after permanency. So here you see is a graph that looks at caregiver changes and maltreatment re-reports within the sample of kids who had entered foster care and had achieved a permanent placement. You'll see that there are caregivers changes going up throughout adolescence, starting about age 12. That includes adopted kids. That means disrupted adoptions. And you see maltreatment reports, CPS reports continuing, you know, roughly around 30% and about 30% of the sample after permanency until about age 12, where it drops. You begin to see the rate dropping. So what we felt very strongly is that foster children, any child who's ever entered the foster care system needs continued services, and the families, you know, the parents in permanent placement need continued services, because a permanent placement does not ensure a stable environment. In the short term, as I said, adopted children had fewer problems than those in other placements, but this was not necessarily true in adolescence. Reunified kids had more problems, but they did feel more socially connected. So some of our recommendations related to permanency is to be sure to adopt a long-term perspective. Once a child has entered foster care, follow that child. Give the permanent family the support they need, and the child the services they may need. Expand our concept of stability. So just because a child has entered a permanent placement, they need continued care. Determine services according to a child's maltreatment risk or status, not according to a child's official placement. Don't lose kids after they're adopted. We would like to see, this came directly actually from the North Carolina meeting, develop policies that address both formal and informal kinship, foster, and living situations, and make more services available, especially to those informal kinship arrangements. And now I'm going to turn it back over to Jonathan, who's going to talk about prevention and well-being.
Thanks, Liz. Well, one of the themes that emerged from this research is the importance of social support. Social support of caregivers reduces the risk for and the consequences of abuse and neglect in children. So the recommendations that follows from that observation is that we need to continue to promote and evaluate evidence-based programs among high-risk families that include a social support component. Our colleague Howard Dubowitz at the University of Maryland was very focused on the role of fathers, and a lot of these results are as a consequence of his initiative. Father presence is associated with a number of improved outcomes, including better cognitive development and children's perceived competence. However, the presence of a live-in boyfriend increases the risk for maltreatment relative to the presence of either a biological father or no father in the home, no father figure in the home at all. So children who report more support from their fathers show less depression, greater social competence, and were more socially accepted. And yet some fathers may feel intimidated or inadequate as providers of child care. So we recommend that we should remove barriers to fathers' involvement with their children. And involvement shouldn't be limited to financial contributions, by the way. Programs and policies could convey to fathers and father figures how their children can benefit from their involvement, and we need to figure out how to help fathers feel more competent in parenting. Back to Liz.
You want to stay here?
Well, I'd love to stay here. Get to sit next to you.
There we
What could
go.
be better?
All right. So our overall conclusions, which again are drawn from our stakeholder meetings with professionals around the country working to prevent and to intervene with in the lives of children who have been abused and neglected, The first one is really to take a public health approach to child maltreatment. And I think North Carolina seems like it's been great in this in the last decade. So the public health approach is community-based, it's evidence-based and data-driven. It would address all types of maltreatment and witnessing violence. And there would be a strong emphasis on primary prevention, which is giving families the support they need and children the support they need before maltreatment happens if they are at risk. The very early identification of families or children who are at risk. And tertiary prevention would include the things like making sure that children who have entered the foster care system continue to receive services after they enter permanent placement. We believe that that would result in fewer emotional, behavioral, and physical health problems among children and youth, fewer school problems, and less youth violence. So what are our next steps? Our next steps, we believe that it would be great to increase the commitment to prevention, including more funding for prevention programming and more prevention research. We would like to see child maltreatment and witness violence exposures included in any federally funded survey assessing child well-being. It's frequently left out because it's scary to ask kids directly about child maltreatment. There's a perception that it will be disturbing to the child. Researchers may not know how to handle a report. There may be ethical concerns associated with reporting. And again, we found that we were able to do this in what we felt was an ethical way that did not disturb kids, and kids that we asked that did endorse maltreatment, and even kids that we had to report because they revealed maltreatment that was previously unknown, continue to participate in our research study. And again, all systems serving children, child welfare, school, health care, should strive to include fathers. What we heard at our meeting will come as no surprise to you, and that was that frequently take a school-based meeting, IEP meeting, occurs during the day, very difficult for dad to get off work. Mom shows up, so once again, dad's out of that loop. Who typically brings kids to the pediatrician's office, right? It's mom. We would like to see all systems serving children striving to incorporate fathers more because of the contribution, the unique contribution fathers can make to children's well-being and a family's well-being. And that's the end of our presentation. And do we have a question session now?
Yes, Layla's the
Oh. So say it, Dr. Katz. All right, thank you both for your presentations today. We're going to open the floor up for a brief question and answer segment. We'll entertain questions from here in the room. Also, those of you who are joining us online, please feel free to tweet your questions to us at NCKidsCount using the hashtag LongScan. And before today's webinar, we also gave you the option to email your questions to me directly at layla@ncchild.org. And I want to kick us off with something I thought was particularly interesting, because I know, Liz, you've been going through the Science to Practice grant kind of across the country and across the state to talk about these findings with both practitioners as well as policymakers. And I'm curious if you have examples from the field of how this research is being used to really help inform and improve practice at the local level. So how are folks translating this research into direct action?
Well, I think an example of how North Carolina in particular is translating this research into action is and I might get the name wrong, the Child Trauma Treatment Program for children who have experienced great risk and adversity, loss, trauma, that kind of thing. I think that treatment program is evidence-based, and it's not limited to children who are still in foster care or whose families are continue to have involvement with CPS. I believe that it includes kids who may have been adopted, kids who have moved into permanency. So that would be a great example of continuing services being available to children in permanent placements, for instance.
Another example of a possible consequence of these findings in North Carolina is the Child Fatality Task Force has opened up a renewed interest in that high priority infant identification and tracking form, and I think that they have been considering bringing it back if there were a way of doing that.
And the Child Fatality Task Force, I believe, also has had a continued interest in disrupted adoptions. So So, and then there's an example of things like the Circle of Parents program and the Triple P programs and things like that, prevention programs that Circle in particular offers support to parents who may be at risk or parents who just would like some support from other parents like themselves.
Tom?
I've been working on the issue of corporal punishment in the schools for quite some time. And it's, when we got to the legislative approval that we could hit a child only if the parent approved, that definitely reduced the occurrences dramatically. However, we're left with a number of parents who think it's okay for a school administrator to hit their child rather systematically, not a spur of the moment thing, ritualized kind of process. And what, and you even hear legislators feel like, well, I was hit and it was okay. But at what point is being hit maltreatment? I mean, is there a point where it's not maltreatment? It's just become very fuzzy.
I'll try to restate the question. Tom is interested in the issue of corporal punishment and observed that when the legislature passed a law that required parental permission for school administrators to administer corporal punishment, that the frequency of corporal punishment in schools went down, but there remains a core group of families which believe in child maltreatment and believe in corporal punishment. And Tom's question is, at what point does corporal punishment become child maltreatment? And I have to say that that's really more of an ethical than a research question. So I can share some thoughts with you about that. I mean, I personally consider that any act of violence or aggression against a child is on the same continuum, that there isn't a clean break between what we consider to be corporal punishment and what we consider to be maltreatment. As you know from child protection, we have to demonstrate harm in order for a physical trauma to be labeled physical abuse or maltreatment. But I think we know from other research, and I would cite Adam Zolotar, the vice president of the North Carolina Institute of Medicine, who has researched this specifically, that in fact the efficacy of corporal punishment as a way of managing children's behavior tapers off rather rapidly over time. And we don't know that there is any good evidence that corporal punishment actually improves children's behavior at any age. It probably makes the parent feel good, but doesn't do any good for the child, in fact. So I would think that if you're actually harming a child with no documented positive consequence, that's abuse.
Yeah.
And they track really well with GA studies, which is being utilized now as psychology in Washington State and Vermont. So I'd like to, I guess my question is more how we continue to utilize these recommendations in North Carolina for policy. I really think that this public health approach is huge in early childhood, so that it's it's not sitting just with child welfare, which gets folks after the fact, but that we use the universal prevention programs, promotion prevention programs like Triple P, so that we're not focusing on particular populations, folks, not targeted populations, but we're focusing across the board, and that people get help. And we do really, really early identification. We can do that. You do early identification. Those are the things that we're really need money. Money is key. It does universal home visitation programs. In Durham, we have Durham Connects, the universal home visitation for babies. And so everybody gets that. It doesn't matter whether you're a corporate banker or whether you're getting candidate funding. So think those are the kind of things that we have to push in order to kind of normalize a lot of this child development issues in education across the board, not only with our child-serving agencies, but across the board in our culture. So that's a long way to say, how do we use it again in North Carolina to really start developing policy, and how can we use North Carolina child?
You need to restate that for the audience at home, I think.
So we had a comment that also just emphasized the importance of the study, also cited some examples from across the country of how LongScan is being used to inform and develop policy. And so the question becomes, how do we in North Carolina use these results and findings to help improve our policies? And what's the space for an organization like NC Child in that particular activity?
I think the space for an organization like NC Child is to continue to advocate for evidence-based programming and to continue to advocate for prevention. I also think continuing to advocate for children who have ever entered the foster care system and the families caring for them and their need for continued services is an important role that NC Child could play.
And I would say that support for programs to prevent child maltreatment crosses political boundaries, and we can't presume that there are constituencies whom we might be surprised would support initiatives on behalf of prevention of child maltreatment that we wouldn't have guessed. So it's important that groups like NC Child, keep those channels of communication open, both sides of the aisle, so to speak. I'm not that well informed about policy making since I've spent most of my career in research, but we all, I think, have a lot to share with policymakers, and this kind of coalition that NC Child represents is a very good place, to begin that process.
Sorry, we're working with the mic here. This is Rob Thompson at NC Child. A couple of questions. One is, really maybe it's just one question, but I think one thing that struck me was how bad the outcomes are for children who are going back to permanent placements, both in terms of the re-reporting of abuse and neglect and maltreatment, but also just in terms of all the risk factors that they're exposed to in those placements. That was the thing that surprised me most. Was there one thing that you found in the LongScan that surprised you or was unexpected more than anything else?
I think one of the findings that we keep coming back to that's critical, and that I'm not sure that I would call it a surprise, but it's a significant thing, is the idea of being able to identify children at birth. Jonathan, I think that the kids that Jonathan showed you that slide of the sort of the relationship of cumulative risk to maltreatment report. So, we know the kids who are at highest risk for maltreatment. We know them very early on, and it's a wonderful opportunity to intervene and prevent that maltreatment from ever occurring.
I have one surprising finding that I'll share, but before I do, I would say that the observation about the lack of permanency and the problems that children from foster care who are placed in permanent reunification with their families has caused us a lot of grief. There are a lot of people in the foster care child protection world who didn't want to hear that. And remember, our kids were particularly at risk at the time that they were recruited, so they don't represent a cross-section of all maltreated kids, and certainly they're not at all a representative sample of all children in the United States. But nevertheless, among our kids who were in foster care, who would be no different from other kids who were in foster care, those permanent placements with the families that abused them in the first place were not such a great idea in many cases. So that's why Liz emphasized how important it is to continue to follow the children after they have been permanently placed someplace. Now, my own true confession with respect to what surprised me the most about the LongScan findings has to do with my prejudice about mental health as opposed to physical health. A pediatrician, we don't get a lot of mental health training, and we kind of didn't appreciate the importance of mental health problems in our parents and the parents of the children that we saw. The big take-home message for me, which didn't come out in any of these findings and recommendations, but it's kind of behind a lot of what we saw, was maternal depression. Maternal depression as a risk factor is huge. I mean, that is one of the adverse childhood experiences that we did measure. It affects not only the risk of maltreatment, both neglect and abuse, but it also affects the way that abuse affects the children in the long run. So children who are abused and also have a mother who is depressed have far worse outcomes than children who are abused but whose mothers are not depressed. So that for me was a huge revelation.
I have a question as it pertains to father involvement, whether or not that was much of a surprise or not, and having seen programs that have been successful at, increasing that parental involvement, and more so, I'm thinking about the fathers who are incarcerated, more so than those who are not incarcerated.
Speaking from a public health,
Repeat the question just a little bit the best you can.
yes, the question had to do with how to increase fathers' involvement with their children, particularly, say, fathers who may be incarcerated and that kind of thing. If you take the public health approach as your basic premise, that would put the responsibility on the systems, right, in which families are interacting with. So it would put the responsibility back on the education system or the prison system or the law enforcement system to say, we need to find ways to maximize fathers' involvement with their children within our system, rather than focusing on the dads themselves. What we heard in our meetings again and again from children whose fathers, from adults who as children had been involved with CPS, they felt the tremendous loss of their dads, and they felt that their dads, that there were barriers to their father's involvement that were not of their father's own making. Does that have anything to add, Jonathan? I'm not sure. I'm not here.
Well, all I can say is what our colleague Howard Dubowitz is doing in Baltimore, which is have father groups trying to actually do some parent training with fathers who may not be resident in the home with the child, but who want to be involved. We did find across all 5 sites a lot of desire for fathers to be involved that was blocked in one way or another, either by their own sense of inadequacy or by bureaucratic barriers. So working directly with fathers in father groups, giving them confidence, assuring them that it's not about the money, that the kids really need their emotional support and their presence.
And an example here in North Carolina would be the Circle of Parents programs that focus on dads.
I think to dominate the conversation, but also talk about allowing the children to listen to their parents while they learn. That, produce those barriers so that the children can have access that way.
Well,
Phone calls, letters.
Lana was asking about why shouldn't children be able to visit their parents, their fathers specifically, if they're incarcerated, and communicate with them by phone or by letters. And we didn't follow that specifically in our study, but it sounds very reasonable to me.
This is my name, Mrs. Tyler. I just have a comment followed by a question. So I'm interested in positioning this in the broader argument. And so I want to preface that by saying we know that high levels of disparity cause increased risk for social incohesion. So societal incohesion, which starts in the family and then translates as they become adults. I know you have some research on that. In the groups that you looked at, did you quantify by level of disparity, also understanding that child abuse and neglect can run the gamut? So I'll say that I understand that. However, looking at prevalence, did you find that the correlation in terms of levels of disparity resulted in increased risk of child maltreatment?
I have to say we didn't study that specifically. You know, when we started this research in 1991, I don't think disparity was on the map. You know, it's been 23 years since then, and now we're more concerned with disparities, and that's the type of thing that we hope people who are interested in manipulating our data themselves would go back and ask. I would say that we saw very little differences in our population across ethnic groups or across cultural groups or racial groups. As I said, and Liz said, that the children were selected because they were already at risk at some level or another, and within that population, we didn't see statistically important disparities across racial or ethnic lines. It was already a narrow, and that's exactly right. Linda said that that was already a population that was very focused, and that's true. We did not have a lot of variation in our population.
Yeah. And the other thing to add is the bulk of our families were poor. We're living in poverty. So by definition, facing a great deal of stress as a result.
It looks like we've received a question via Google+. Someone mentioned that you discussed the importance of child protective services and shelters working together to support families, and they would like to know if you'd have any examples of NC shelters or child protective service agencies that could serve as a model for these partnerships.
I think that might be a question that this group could answer more quickly than Dr. Koch and I could. So I'd like to turn it over to the group. Yes.
We have a model in Alamance County.
Can you come down to the...
Can you say us on the mic? It was on like what? Sure. Thank you. Keeping you moving today.
So in Alamance County, we have established a model in which we have a team of child welfare workers that are co-located in the Family Justice Center, which is domestic violence related. It probably hasn't hit its peak in the correlation of work with the Family Justice Center, but I think we're still working towards that team being specifically working with children who have been exposed to domestic violence issues, and so that's a work in progress.
So one of the things that's really topical is we're seeing a lot more interest in return on investment and this kind of cost-benefit analysis being applied to public policy, not only in our advocacy work, but in the development and implementation at the General Assembly. One of the findings that you guys identified was the importance of the impact of kind of early exposures to maltreatment, and yet we're seeing a divestment from early investments in a number of key areas. That's troubling for us as advocates and also perplexing to those of us that use your research to inform our work. Can you talk a little bit more about some of the findings that you've identified about the importance of those early interventions during the earliest years and what that means for children to be exposed to maltreatment, abuse and neglect, and the long-term implications of that in terms of their successful transition into adulthood? That's a big question.
Right, and I wish I had a good answer. We didn't do any cost-benefit analyses. What we did do was, look at these risks and try to predict, based upon the risks that we saw, what the outcomes were for the children. And the bottom line is that the greater the number of risks, the greater the likelihood that the children would be reported for maltreatment, and also the greater the likelihood of the kinds of adverse outcomes that we measured, which had to do with aggression and delinquency and emotional difficulties, behavioral difficulties, school difficulties. So all of those kinds of things would be greater in the long run in later childhood among children who had a number of these early adverse experiences, among which child maltreatment would be included. So the take-home message from that is that if we could invest more resources in prevention of those early childhood adversities, we would wind up spending less money on mental health services, social services, school services, and juvenile justice. The problem with policy is that the people who save the money later in childhood aren't the people who have to spend the money in early childhood. So we can't expect public health or social services to benefit necessarily from the school improvements or from the juvenile justice improvements and savings, and that makes policymaking very hard. So we have to have a holistic approach about policy the same way we have to have a holistic approach about children if we're going to see those benefits.
Are there any other questions from our live audience or online? I did get a couple of emails. People are curious if they'll have an opportunity to access the slides or the recording of the presentation. I've received several of those emails, and you will. Rob will send that out after today's presentation. And we have a question in the audience from Tom.
Since we're winding down, just a comment about predictors. Jonathan and I grew up in a joint community just outside New York City, and the prediction was he wouldn't even reach adulthood. And he's gone on to become a distinguished professor, so I congratulate him on the work he's done.
You know, send that one up to people online.
So basically, our children will live up to our expectations of them, and we have two stellar folks from the same community who defied those expectations. All right, so any other final questions from in the room or online? If not, I want to thank you all for joining us for this Google Hangout on Air. Special thank you to Dr. Koch and also Liz for coming to join us in the room, as well as folks who have participated online in our very first webinar. As I mentioned earlier, you will receive a copy of both the slides as well as a recording of today's presentation via email after the event. If you'd like to get more information about how to attend similar events in the future, please feel free to visit our website at www.ncchild.org. And you can also learn more about our Child Advocacy Network, or CAN, while you're on that website. So thanks again for joining us, and we hope you have a good day.